Okay. This was a slideshow we started. I think this one started to get weird. This is where it started to get weird with everything we're dealing with right now. So, just a quick review. We talked about these things in the last video, but just real brief, very, very brief, quick reminder. So femur is the thigh bone. Patella is your little rock skip or kneecap bone. Tibia is the large shin bone, and you tell which tibia it is, left or right, with the malleolus. So it's always the medial malleolus because the tibia is on the medial side. And then the fibula makes up the lateral malleolus. So if you need to see the old video, go ahead and take a look at it. Here is a picture of, you can see on your left is basically anterior view and the right is posterior view. So there it is. We went over joints last time as well. If you know the bones, then the joints will come super easy. So you could pick out, hopefully, that the tibiofemoral joint is going to be where the tibia meets up with the femur, or that the patellofemoral joint is where the patella is gliding across the femur in that, where it's supposed to track in the patellar groove. So now we're into the soft tissues. And the soft tissues, if you look at it, first thing we're going to look at are the pillows of the knee. So always orient yourself with the knee by looking at the fibula, especially if you get this kind of a cut. The fibula and the tibia are cut off. Fibula is always lateral side, tibia is medial side. And that big bump that that line is pointing at on the tibia, well, that's the tibial tuberosity. Look at that. So a third of the meniscus is vascular. That means that it has a blood supply. The rest of it is not. So sometimes that will start to kind of shift away. Sometimes if you have the two bones kind of squished together and scrape up the meniscus, you can have little pieces of it kind of float up. So if that happens, if you grab hold of your tibia and kind of shake it back and forth, you can hear it click, 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 click. And I've had students have that in the past. Kind of interesting. So here are the ligaments of the knee. And again, this was one that we talked about a little bit while you guys were, I think we were missing maybe 7 or 8, maybe 9 kids. But it was when it started to get weird. This whole thing has been like the weirdest. I feel like I'm in an episode of The Twilight Zone, and I'm waiting to wake up, like, and actually put real clothes on, not pajamas. So, okay, ligaments of the knee. The MCL is going to be the one that you're looking at it'll be on your right side because we're looking at a right knee. So, and it's facing us. So we're looking at the anterior view of it. The medial collateral ligament will connect the femur with the tibia. And it's going to resist valgus forces. So maybe I'll have to draw this up there real quick, but remember, valgus is when like the knees come together. So there's your picture. Woo. So it's when the knees come together, like this kind of knock knee position. I think of it like valgum, like there's gum between the knees. So it resists forces that are pushing the knee towards the midline. And then the LCL is on the opposite side. That's the lateral collateral ligament. And you'll see it on this paper as the fibular collateral ligament. But it's supposed to be, most people know it as the LCL. It resists varus forces. So the opposite of valgus is where we have kind of a bow-legged position like this. And the knee is kind of forced out away from the midline. And if that happens, then the lateral collateral ligament can go. So understand that valgus and varus forces, like when they happen, the valgus force will tear the MCL, the varus force will tear the LCL. But if it's a hard enough valgus or a hard enough varus, then it can tear other things as well, like the ACL, like the posterior cruciate ligament. So this slide also gives you what it resists. So if you look at the MCL, it resists valgus forces, but only to a point. and then LCL resists varus forces to a point, and then anterior cruciate ligament is going to keep the tibia from coming forward, and the posterior cruciate is going to keep the tibia basically from going backwards. So all to just keep it as a an extension, your flexion extension joint. That's pretty much what we hope for there. It's a load-bearing joint though, so a lot of bad things can happen. So major tendons that we have, you can see above the kneecap on the picture on your left is you can see the patella, and you can see right above the patella, they call it a quadriceps tendon, and technically like a ligament is bone to bone connective tissue. So a lot of people will say, well, that's a ligament from the patella down to the tibial tuberosity, but really it's continuous with the quadriceps muscle, and that sesamoid bone forms within that connective tissue. So they call it the patellar tendon. So if it's distal to the patella, it's a patellar tendon. If it's proximal to the patella, then it's a quadriceps tendon. And then we have the Achilles tendon. And if you look at the picture on your right, sometimes this is also called the calcaneal tendon, because look where it attaches, friends, right on the calcaneus. So if you look at the muscles that's attaching to the calcaneus there, you've got superficially, that's the gastrocnemius, and then beneath it, you have the soleus muscle. So that's going to give you your, basically when you pull on that muscle, you're going to get plantar flexion. Okay, some muscles of the lower limb. You should know that the quadriceps are 4 separate muscles at this point. You should know that the quadriceps sit on the front of your thigh, and because they sit on the front of your thigh, I always, when you're like, man, I just don't remember what these muscles do, like touch yourself, play with the muscle and see what happens. So if I kick my leg out right now, which I just did, and I shifted, so who knows how this is gonna look, but you kick the leg out, the knee extension, you can feel those muscles contract when you kick the leg out. So when you're on a leg extension machine, that's going to work it. But really, like, that's a machine you shouldn't use, because most Americans are really strong in their quadriceps, but not so strong in their hamstrings. So not necessarily a need to isolate the quadriceps when you can hit it with a squat or a lunge or a leg press or a wall sit or something like that, where we're not putting so much stress on the knee joint for an isolated exercise. On the hamstrings, on the other hand, most Americans are pretty weak there. It's 3 muscles. So I always think of the quadriceps as like the 3 vastus and the rectus, and I think of the hamstrings as the 2 semis and the biceps. So remember, in the arm, the biceps brachii, when it's contracted, it flexes at the elbow. When your biceps femoris, which that is spelled wrong, and I'm just looking at it, it's the big pes femoris. Sure, it's biceps. It should be biceps. When the biceps femoris contracts, it's in the back part of your thigh, and it's going to cause knee flexion. So you get elbow flexion with this biceps, knee flexion with the other biceps. Wow. So here's where they sit. So you have a picture of it. So front of the thigh, quadriceps, back of the thigh, hamstrings. Okay, and then this one's giving you some muscles just kind of behind the knee. So if you remember, the knee itself is called the popliteal, or the back of the knee is called the popliteal region. That's we also have a popliteus muscle there. And when you cut away the gastrocnemius, you can see that deep soleus. You're going to hit that with a seated calf raise. The gastrocnemius is more of an straight leg, basically plantar flexion. Okay, in the foot and ankle, we did cover these. We have 7 tarsals. The main ones you need to remember are here. The calcaneus is the heel bone. The talus is the one that sits right below the tibia, and it's kind of the head of the hat, the ankle hat that we talked about last time. Then you get to the foot bones. There are 5 foot bones. Just like in your hand, we have 5 metacarpals. In your foot, we have 5 metatarsals. And then they meet up with the little phalanges. So on our upper extremity, because I can show you, it is the fingers. On the lower extremities, it's the toes. Remember that the tibia has the medial malleolus, and the fibula makes up the lateral malleolus. So here is a picture of it. You can see at the bottom end, or the distal end, the ugly date is where we have the ankle hat. At the top, you can see the tibial tuberosity. You can see where the pillows will sit. Okay. And then we're into the joints of the foot and ankle. So again, this is kind of review, and so I just wanted to go over this in rapid succession so we could get to the things that we actually haven't covered. So you can see that there's a tibio-talar joint, and just think of the word tibio-talar, tibio-talar. Tibio is going to be the tibia, which is the large shin bone, meeting up with the talus, which is going to be that top ankle bone. And I just pointed at it again because I can't help but talk with my hands, and this is ridiculous. So, okay, talus is right underneath the tibia, right, and you can see it touching the fibula there. The subtalar joint, sub always means under or below, and in this case, we're talking about the talus. So it joins between the talus and the calcaneus, and it allows for some inversion eversion. So just so you have the tibio-talar is going to give you plantar and dorsiflexion. Midfoot is where the tarsals meet the metatarsals. So we haven't really talked about that one. There's a midfoot joint. Doesn't have a ton of flexibility, but some. But there's the midfoot joint. Then we get to the MP, which is going to be where the metatarsals meet up with the phalanges, or the money knuckle on the upper extremity. And then the interphalangeal joints, we've got the ugly date and the acute date. So this one on the fingers is the proximal interphalangeal. This is the distal interphalangeal joint. Same thing will apply on the toes. You will have a proximal, so a pip and a dip on each of the toes, except for the large toe. The big toe only has an IP, one interphalangeal joint. So the picture on your left is the medial side. So we're looking at, if you can see, there's the tibia. So tibia is always medial. So you can't see the fibula in this one. That means that we're looking at the medial side. So we have the calcaneus there. You can see that the tibia has this really large ligament that's connecting down to the talus. And they call that the deltoid ligament because it looks like a triangle. So that's going to resist eversion to an extent. If you evert hard enough, a lot of times you'll break off the tip of the fibula on the other side and tear the deltoid ligament. But on the opposite side, we have the anterior tibiofibular. If you get that one torn, and that's called a high ankle sprain, or there's another posterior tibiofibular. There's an anterior talofibular and a posterior talofibular. So there's the lateral side so you can see it. So if there's an anterior, there's a posterior. And just kind of look at the names of the bones. That's going to give you big clues as to where they live. Okay, and then we get to our soft tissues in the lower limb. So muscles, we have a tibialis anterior for dorsiflexion. So remember, dorsiflexion is bringing the toes up towards the shin. And the gastric soleus are going to give you plantar flexion. But because the gastric actually crosses the knee joint, you get some slight knee flexion. Tibialis posterior, I'm going to show you a picture of that here. You can see where it sits. It's going to be right next to the tibia, just posterior to that, kind of medial. So it's called the deep posterior compartment where it sits. And remember, this is the bad shin splint one. If this one gets shin splints, so that muscle is starting to get inflamed, it pushes into other structures, and all it has around it are bones and muscles. So it doesn't really have room to stretch, so it can cause some real problems. Okay, so here are the muscles, just so you can kind of see it. They break it up kind of by compartments in this lower limb. So if you were there the last day of class, I gave you a muscle sheet and told you kind of what those actions were. But it gives you this on this page, and I'll post that in case some of you are missing. But there you can see this is a transverse cut of the lower leg, and you can see how the muscles sit a little bit better like that. Okay, injuries. What we have for injuries is a thigh contusion. So that's if you just get a severe blow. I had a good blow when I was coaching softball a couple years ago. Got a line drive right to this side. It would have been the lateral side of my left leg, and it swelled like crazy. They actually thought that I maybe broke the proximal side of my fibula, but it wasn't broken. It was just really inflamed. So it was a contusion. So it can be from direct impact, severe impact to a thigh. So think baseball, softball, a lot of times get this, especially if you think of a catcher playing in the dirt and those fastballs coming at them. Sometimes they get it right in the leg. They do have padding, but it doesn't always protect them from what they get. So not much you can do for a bruise other than ice and compress it, and just make sure you're paying attention in the future and wear protective equipment. We have muscle strains. So this is one where we've actually lost one of the heads of the biceps. It's torn completely. So there's a sudden stretch or a contraction of a muscle, and you can have pain or spasm. And there's the treatment, and obviously we want to warm up. The biggest problem with connective tissue is it needs to be warm before you just start getting it moving. And the older you get, the more important that warm up and the cool down will be in terms of keeping that tissue safe. So just to remind you of the different types of strain, a grade 1 is a micro tear. You're probably going to be fine from that in a couple of days. A grade 2 is a moderate. And then 3 is a complete rupture, which is what I showed you on that one. Okay, for other injuries, we've talked about the MCL sprain. We've got a valgus force coming in, so you see the arrow kind of coming after it, and it's pushing the knee medially, which will tear the MCL. So there are the symptoms. Always think of when the possible instability is there. A lot of times the patient will describe that as, my knee just feels like it's giving away. That's all I can describe is my knee feels like it's giving away. So MCL strain, you get that with a lot of them. So again, healthy MCL, there's a grade 1, 2, and 3. With an LCL, it's the opposite force. So you can see the arrows coming in from the medial side, which is actually making it so the lateral collateral ligament is toast. So again, you're going to have pain, swelling, stiffness, and then this idea that like, oh, my knee just feels like it's giving away. So strength and condition, if it's ruptured completely, that's going to mean surgery. Dang it. Okay, and then the ACL, this one you hear about a lot. So sometimes this comes from, the mechanism can be like you stopped fast and then you turned. So there's a little bit of rotation after you've decelerated. Happens a lot in basketball, happens a lot in soccer. Basically every sport where you're moving and shifting positions. Tennis is another one. The ball goes over there and then it quickly comes over this way. That's when you're at risk for popping that boy. So a lot of times you'll hear it and you'll feel joint stability. Remember, we still have the patellar tendon in place, so it will still feel like you have some support there, but it just feels like your knee's giving out. So rice surgery, you can see the treatment there. And obviously strengthen the knee where you can. Get it warm first and then strengthen that bad boy. Okay, PCL. This one you can see the PCL is supposed to stop the tibia from posterior translation. You can see in this picture that it's clearly posterior translating. So that suggests the PCL is gone. But every now and then you have some things that can happen, because you have PCL as the posterior cruciate ligament, or PLC, which is like the posterolateral compartment of the knee, and the symptoms are very similar. Okay, with a meniscus tear, this is another weight bearing with rotation kind of deal. So a lot of times you'll see not only an ACL go, but like meniscus will come up a little bit. So if it's avascular, meaning it doesn't have blood supply, they'll surgically trim it and smooth it out. If it's vascular, they will surgically repair it because they're going to want to save as much of the vascular tissue as they can. Okay, here is a patellar subluxation. So the patella has come out of the patellar groove. If it happens once, it's going to continue to happen. So if you know someone that has their knee come out like this, my best friend in high school was like this. It was like if we sat cross-legged, her knee a lot of times would go, and she'd have her dad come and straighten her leg out. But yeah, this is one that once that soft tissue is stretched, it's likely going to stretch again. The first time is going to be the most painful time it happens, but you can do things like brace it and try and keep a little circle brace around that patella to try and support the tissues around it. Make sure you warm up, get the right range of motions, do strengthening exercises, but bracing is probably the best option. People will try KT tape for a while, but it's spendy stuff and it gets old after a minute. Oh, there's after operation kind of deal. Or maybe they were taping it. I need to look at that again. I don't know what the heck that is. That looks like toilet paper with, yeah, they're probably hoarding. They're probably the ones hoarding all the toilet paper. What the heck? Dumb idiot. Okay, we have jumper's knee that comes from repetitive deceleration and worse when jumping and running. So it's just tendinitis it's inflammation of the tendon is what's happening. So if you're constantly stressing that by jumping and landing, it will eventually give you some trouble. Okay, these notes are all on Canvas. So as I'm going through these fast, realize you can go through them a lot slower and take your time with it. But with this one, PFPS, tight hamstrings and calf muscles, increase the Q angle, weak quadriceps, poor foot mechanics. This can all cause patellofemoral syndrome. So they're going to have tenderness on the patellar edges, a dull ache. Crepitus just means like sounds. It's going to be like clicking sounds when you walk. It's usually benign, but it sounds worse than it is. Pain with compression. So treatment on this, they're going to say NSAIDs, which stands for non-steroidal anti-inflammatory drugs. We need to strengthen the quads, do some taping, and maybe some orthotics in the shoes, because if you're off at the base, you're going to be off everywhere up the body if you wait long enough. Okay, then we have shin splints. So remember, we can have these in the tibialis anterior, and we can ice those, just massage, maybe get a paper cup, tear it back after the water's frozen, and then you can massage the front of your lower leg. But really, the tibialis posterior is where we run into some real big problems, where it pushes into, I don't know why this is pointing at, this posterior tibialis one is pointing at the soleus muscle. So, all right, I don't know what it's trying to, oh, it is, so no. Meep. Okay, that's a terrible picture, but it's pointing the posterior tibialis at the soleus. That's not where it is. So it's right next to the bone, and it will push into the bone. And that's kind of what we think Kevin Ware's injury came from, was it was like tick, tick, tick into that tibia until when he went to block the 3 and tibia's out of the leg. Okay, we have ankle sprains. The more likely one is going to be an inversion sprain. That's going to get your anterior and your posterior talofibular ligaments, as well as if you go high enough, it can get the syndesmosis, which is basically this connective tissue between the tibia and the fibula. You can get the anterior tibiofibular ligament or the posterior tibiofibular ligament if it's a high ankle sprain. Or you can actually get the calcaneofibular ligament, which is connecting the calcaneus and the fibula. Worst case is if you roll it so bad in an inversion sprain, so the bottom of your foot comes in, but you roll it so hard you get all those ligaments on the lateral side, and then you can even make it look like an eversion sprain because it's going to tear that as well. Yikes. Plantar fasciitis is another one. So we would roll out with a tennis ball on this one. Usually feel the tightness first thing in the morning, and it makes it so it's a little bit painful to walk. If you can kind of warm up and then roll out, like I said, sometimes they have a heel cup, but usually a tennis ball works. Just roll it out on that. That can help. Orthotics are also a good idea for this guy. And finally, I think turf toe is where we'll stop today. Turf toe is at the MP joint, and it's basically like overuse or trauma. So maybe like hitting your toe against something and causing that joint to just compress. So we are going to stop there today, and I hope you're doing well. Call me if you're not. I'd like to help, especially if there are issues with getting you food in your body and things like that. We want to help. Please keep in touch over email, over Canvas. I'll put this assignment out first thing tomorrow. Thanks.